It's clearly talking about me.
Yeah. So we got a comment on Instagram, or not Instagram, iTunes, and it said, their reviews of pharmacotherapy are like okay and like stuff, and it said, but I hate their voices. It said, I hate their voices. And it said, especially that kid that's all monotone. What's going on, everybody? Welcome back to another episode of the Core Consult RX podcast. And today we're talking about hepatitis.
Yes, we are.
Cole, what's up, man?
I am kind of tired, honestly.
Yeah?
It's been a long day.
Short, 14-hour day?
Yeah, ish.
That's why you're in dress clothes and I'm in shorts.
Yep. That's pretty normal, right?
That's true.
I've tried to be
I wear this to work, actually.
I've tried to be a little more casual with the podcast.
Yeah,
Some t-shirts and shorts and things.
Been really changing it up.
It's got to be like Mike.
Well.
You ever seen that movie?
A long time ago.
Yeah.
It's not one of my go-tos necessarily, but I'm sure if it was on Netflix, I'd check it out.
It's a throwback.
I watched Space Jam the other day.
You know what? Whenever this happened just like a couple weeks ago at a meeting, whenever somebody asks, tell us something, here's your name, where do you work or whatever, tell us something interesting about yourself. Mine's always that I have not seen Space Jam.
Really? That's...
Exactly.
I would have been like, oh, well, guess who's not getting a job? It's a great movie. My wife made fun of me for watching it, though. I was like, what do you mean? She's like, you're a grown man watching this by yourself.
Like 2 days ago?
Yeah, exactly. Yeah, it was brutal.
I have I have an idea of the plot, but never seen it.
Yeah, it's not great, but it's something to do.
I mean, I don't know. Everybody makes it sound so great.
It's not like listening to a podcast on hepatitis.
That's true.
Yeah.
Yes. Hepatitis. This is the double hepatitis day, actually.
Yeah. We're going to do A and B.
Yes. Because
we already did C.
Turns out A is not that interesting.
A is not that interesting.
Except if you're living in South Carolina right now, there's
Yes.
like an official hepatitis A outbreak that originated in my home county. So that's great.
Nice. Nice job, guys.
Yeah.
And what's that, Aiken?
Aiken, yeah.
See? I just knew where you came from.
Did you know where I came from, or did you just know about the outbreak?
No, I knew you came from.
No way.
Yeah, man.
I don't know what county you grew up in.
I grew up here. That's why.
Well, there's Charleston. You were in Charleston County?
Yeah, Somerville and Charleston. My parents moved. They were like vagabonds. They went back and forth.
Yeah, Aiken County. That's me.
That's cool. Why'd you guys get hepatitis?
I have no idea. From what I read, there wasn't a great patient zero or anything, but some general stats that I kind of remember is like to this point in the year, there's usually like 14-ish cases or something, and there's like 80, something like that.
Jeez.
So we got a notification from DHEC like last week that was like, outbreak of Hep A. So good to know.
Yeah.
We'll talk about it.
Stay away from Aiken.
Yeah. And we'll talk about it. Never mind.
Sorry if you live in
We'll
Aiken.
get there. I'm getting ahead of myself.
All right. So where do you want to start with this, though? I guess we'll start with Hep A since it's less to talk about.
A little shorter.
At least in our small frame of reference.
Not as much treatment, but so Hep A, it's one of the more common causes of acute hepatitis. It was first isolated by Purcell, whatever Purcell is. I suppose that's some, I don't even know.
If only we had looked at the background information.
I know. I think it's, some lab or something. In 1973, so relatively recently. And we, humans, Homo sapiens, appear to be the only reservoir for the virus.
Yes. So otherwise, it's just hanging out there.
It's just hanging out there. And it turns out it can hang out for a while.
Which means you anti-vaxxers, if you guys would quit yelling at us, we could actually eradicate this thing.
Mike, we're supposed to be nice to people.
Oh, sorry. Yeah, you guys are great.
Well, it turns out that it was more or less not eradicated, but really mostly eradicated in the U.S. for a long time. And it still is considered like essentially eradicated in the U.S. Much more common in up and coming countries, I suppose. It is transmitted through contaminated food and water. I think it can live outside the body for like almost 48 hours, but usually only does for like 16 hours, something like that. But since the application of serologic testing in the 80s, we know a lot more about Hep A, epidemiology, clinical manifestations, how the virus starts and ends. So we pretty much got this one whipped if we could,
get everybody vaccinated.
Vaccinate and get the vaccines where they need to be.
So one of the things we're working on with my clinic is we have a pretty prevalent homeless patient population in Charleston.
Yeah.
And so there's a couple of the clinics downtown that are they act as shelters and provide. One of our nurse practitioners actually goes out there a couple times a week and treats patients.
Oh, cool.
And so her and I were actually talking about today about maybe finding some ways to get some Hep A vaccines going out there. I know Dr. Wirt has been out there vaccinating people for Hep A.
He's the man.
So it's something that definitely needs to happen, and that's a big population for people who live in big cities.
And I think that was actually an updated ACIP guideline in 2017 where they said, recommending if you're homeless or could be considered homeless, whatever that definition is, recommended to go ahead and get it, which is good. You've probably, if you've traveled, and you've seen a travel doctor or seen a doctor for a travel visit, you've probably seen this come up, and they had to determine whether or not you should go ahead and get it as an adult. So we'll talk about scheduling. A lot of this will be about the vaccine, but a little bit on the course of the virus and supportive care, that sort of thing.
Yeah. So that's the big thing is with Hep A, unlike the other hepatitis, we actually don't. It clears itself on a lot of cases, and so we don't have an actual treatment per se for Hep A. We can use immune globulin and things like that as far as prevention and vaccination for prevention. But patients who actually get diagnosed with Hep A, it's within 3 months. 85% of patients will have a full clinical and biochemical recovery, and statistically speaking. By 6 months, almost all patients will have a full recovery. That being said, there are patients that can have hepatic failure, which would require aggressive supportive therapy, and it's actually recommended that they get transferred to a center that is capable of doing liver transplants, because that could be the ultimate outcome in those patients.
Yes, it could be. The virus itself is an RNA enterovirus. Viral replication depends on hepatocyte uptake and synthesis, and assembly occurs exclusively in the liver cells, which is why it is causes hepatitis.
Yeah.
And it's almost exclusively acquired from ingestion. I mentioned contaminated food and drink, but also fecal oral transmission.
All right, so we want to go first with this. Just jump into the vaccine.
Let's jump into the vaccine. Yeah, let's do that.
So, Hep A vaccine.
That's what it is.
There's a couple different versions. There's the Havrix is the one that I'm personally most familiar with. There is also the, I think I'm pronouncing this right. I've never actually used this one myself, but is it the Vacta? Vacta.
That's what I would say.
You have to use an accent there. But there's two different dosing regimens. So patients who are 1 to 18 would get the smaller doses of 720 units versus the patients 19 and older would get 1,440 units. And the schedule ideally would be 0, 6 to 12 months after that. So a 2-dose series. And it also comes as a combination with the Hep B vaccine, where you can get the both vaccines with one shot, and in that case it's still a 3-dose series to account for the Hep B, and you would get 3 doses of the Twinrix in that case. So if a person does want to get them together, then they can do that. So
if you do get let's say you're an adult and you're going out of the country in a month, and got to get these vaccines, you can go ahead and get the first dose, and you're considered covered for that trip. But then within, the 6 to 18th month period, you want to go ahead and get the second one for long-term immunity. I think it's 90% effective if you got the one dose, but it goes upwards of 97% if you get both, and, potentially lasts longer because that's how it was studied. So that's definitely what would be recommended long-term.
Yes. But no, that's a good point, because that actually will come up for those of you who work in retail pharmacies. I know I had that question asked with Hep A, because they were leaving for one of the countries in Africa, and they were going to leave in 3 weeks, and they were getting their first dose, and I was like, okay, well, 6 to 12 months, you can come back. And he's like, so what do I do? But that's something that to make sure that it kind of ease their minds that you are pretty much covered. It's to carry on that longevity of the immunity to it with that second dose. And the other thing would be if the person doesn't come back in the recommended time, you don't restart the series.
Correct. Yeah. So you just go ahead with the second dose.
Just get the second dose.
Kind of like Shingrix.
Yeah. Exactly. when Shingrix came out and then stopped coming out for like a year and a half.
It still stopped coming out. Apparently, is it Merck or GSK? I want to say it's
GSK is Shingrix.
What you had, GSK. They build a big facility to continue manufacturing, but it didn't didn't pass approval. So that's a big reason why it's still back ordered significantly.
Way to go, GSK.
Unfortunately.
Just kidding. You guys are cool. You guys got a great vaccine.
They got to be making bukus of cash.
Now we just want to get that vaccine out to people.
They got to be making bukus of cash.
Can't hate on them too much. They made a much better vaccine than Zostavax.
They did.
Sorry, Merck.
And we don't have to inject it in the back of their arms. That's great.
That's dope. So patients, who should and should not get Hep A, or at least I shouldn't say should not, but patients who it's not necessarily recommended that they go out and get it. Healthcare workers should go ahead and get it if they've never had the vaccine before. So those of you who are starting nursing, pharmacy,
that's why I need it.
Whatever school, yeah. Did you know I get it?
No, I actually think if I didn't get it for school, because I don't know that it was. I think I definitely got it when I went to Africa, but
yeah.
I don't think it was mandatory for school.
But the ACIP says that healthcare providers should routinely should be vaccinated, and then also, like we said earlier, patients who are experiencing homelessness, and that they even say that they give a definition for experiencing homelessness. So if you're homeless for a period of time, then you're living in a shelter, living in a mission, single room, facility, whatever it is, abandoned building, you need to get the vaccine if possible, or find someone that will donate the vaccine because it's very prevalent in that patient population. But they ask about, and I'm sorry, I actually misspoke. So I said, should healthcare providers get vaccinated for Hep A? It's actually, the ACIP says you don't have to. I misspoke because the question, if you go on the CDC's website, they have a section called Ask the Experts. I misread the thing on my screen that I copied. It's the question to them that was posed was, should all healthcare providers get it? And they said, no, the studies don't show that the units have an increased risk for Hep A. Hep B is a different story, but so sorry, I misspoke. So for those of you who are about to lose your mind, leave a mad comment. Caught it.
You just fixed it.
Woo, close one.
They also say anyone who desires immunity.
Yeah, anyone can. Exactly.
If you ask for it, you can get it. In South Carolina, you can get it without a prescription. Other states, I know you can't. So it just kind of depends on where you're at. Mm-hmm. You can get it in a pharmacy without a prescription.
Yeah. So one of the things too is patients that have chronic liver disease. Although statistically speaking, you're not necessarily at risk for a hepatitis A infection, they do say that people who have chronic liver disease are going to be at an increased risk for that fulminant hepatitis A, where you get severe hepatotoxicity with the virus, and so that you could actually need a transplant. So it would be recommended in those patients to go ahead and get the vaccination if possible.
I should probably mention the course of Hep A and kind of what you would see. There's 3 potential phases. The first phase is the prodrome, this is similar to Hep B too. You will have mild flu-like symptoms, potentially anorexia, nausea, vomiting, fatigue, kind of non-specific symptoms, myalgias, mild headache. Smokers apparently sometimes lose their taste for tobacco, so that's interesting. That also apparently also happens with appendicitis. Didn't know that. The next phase is the icteric phase, which is more of the acute hepatitis phase, I suppose. You'll see dark urine, bilirubinemia, pale stool will soon follow more than likely, but it doesn't happen in everyone. You might get jaundice in about 3/4 of patients with an acute HIV infection, but it's less likely in children and infants. The older you are, the more severe it's probably going to be. Abdominal pain occurs in almost half of instances, and itching is less common but can be accompanied by jaundice. So that's the second phase. Third phase is more rare. It's the relapsing hepatitis. I guess it's not so much a phase as just it can relapse. It's uncommon of the acute infection. More commonly, if you're older or an elderly person, it's just characterized by a protracted course and disease relapse following what would seem like a resolution. Then it comes back. It's not what you want.
Nope. All right. Anything else with that? Should we finish up a couple more points with the vaccine?
Oh, yeah. What else you got?
Just some other patient populations who it's recommended for. Like you said, all patients who desire to be immunized, but also specifically they mention men who have sex with men, users of illegal drugs, any kind of injectables or non-injectables, patients who have just been previously unvaccinated, but they're planning on leaving the country and traveling internationally should go ahead and get it. And then people with blood clotting disorders is the other one that I often forget about. Yeah.
Some employers recommend a group who might be low risk but potential sources of larger outbreaks, like people who handle food in restaurants.
Yes.
Some require that they have a Hep A vaccine, though cost benefit, we don't really know if it's necessarily worth it, but I don't know. I'd like my chef to be Hep A vaccinated.
So that's actually one of the concerns with a lot of the homeless population patients is because, one of the most common jobs in a big city, especially finding them work would be in kitchens, and getting them trained and stuff. So if they have Hep A and don't realize it, it could be a way of spreading that around unintentionally.
That was part of it. My mom mentioned in Aiken, she said a restaurant that they ate at the next day, somebody with Hep A was serving food, and apparently it was like in the news or whatever, and it happened at a couple places. People were going to the doctor asking for prescriptions because they went to this restaurant that somebody had Hep A in, blah blah blah. So yeah,
yikes.
I feel like I'd want my people handling food to be vaccinated.
Yeah. The other thing, I mentioned Twinrix, which is the combination, but there is a dosing schedule that is a quicker onset, I guess how you'd say, a dosing schedule of days, basically, where you would do 0, 7, and then the third dose 21 to 30 days. And then you also give a fourth dose as a booster 12 months later. So if a person needs to become vaccinated very quickly, you can use Twinrix as that kind of expedited dosing schedule. So I should mention that. And then also, since I butchered the name for the other Hep A vaccine, the ACIP actually says they are technically interchangeable.
Oh, really? Even though they're different doses?
That's what they say.
I thought it had something to do with age.
It says, are hepatitis A brands interchangeable? It says, yes, a number of studies indicate that the two brands of hepatitis, Havrix and Lacta, are interchangeable.
Well, I heard you say the age thing, and I was like, oh, shoot, I should probably be checking ages on these things. But okay, they're interchangeable.
Yeah.
We're good.
So 50 units is basically the same thing as 1440.
50 is the other one? I thought you said 700.
No, 720 is the 1 to 18-year-old, and that's equivalent to 25 units of the 1 to 18-year-olds for the Vacta.
Vacta.
I want to know how to really pronounce that now.
That's probably just Vacta. We're in the South, so we can say whatever we want.
Yeah, we're ignorant. All right. So is that enough with Hep A?
Yeah, just have some quick stats. So between 1995 and 2006, the reported Hep A incidence declined by 90%. To the lowest rate ever recorded, about 1.2 cases per 100,000. I believe that was in the U.S. specifically, but obviously rates in other countries are still pretty high. Urban Africa, Asia, and South America are probably the highest rates of Hep A. And the nadir in America was at 1987. So you can think back to school for what that means.
Perfect.
I think it's pharmacy calculations class, probably.
There you go. All right. So Hep B?
Hep B, let's take it on. It's a little bit more involved than Hep A, right?
Yes. So Hep B is actually a DNA virus. So it's double-stranded. It's enveloped circular virus. And if you kind of compare it to like Hep C, which is the one that most of us are going to be a lot more familiar with, which Hep C is RNA, Hep B is the DNA. So this one is going to attack the liver as well, though. And typically the first 6 months is considered the acute phase. Chronic infection is after that. So similar to the Hep C. They're transmission-wise pretty similar as well. So you can get it from blood, sexual contact, sharing needles, and some of the complications and the reason we're worried about this is cirrhosis as well as hepatic carcinoma. So
yes.
There is a vaccine for this one, though, whereas there's not a vaccine for Hep C.
Correct.
So that's great.
It is.
And then the treatment is going to be NRTIs as opposed to like the NS5A inhibitors and stuff like we see with Hep C. So a little different treatment options. But some of the drugs for Hep B you might actually be familiar with.
And these drugs have been around
Spoiler
a little. We've been able to treat this. Well, I guess now, never mind. You could treat Hep C before. It's just we don't really have a Hep B cure like we do a Hep C cure.
We can
right?
suppress it, but yeah, it could potentially flare up again.
Right. But yeah, it's another worldwide health problem, especially in developing areas. He mentioned what the drug is, DNA virus. If on a stain, it's going to have about half to 3/4 of the time a ground glass appearance of the cells. So that's something you might hear or see. It also has the prodrome and icteric phases that are very similar to the Hep A, but fulminant hepatitis, I think probably a little generally more common and can be more severe than Hep A.
Yeah. So I guess the one of the complicated things with Hep B, at least for me anyway, is that looking at the lab panel. Because there's a lot of letters there.
There are a lot of uppercase, a lot of lowercase.
So it gets confusing. So just kind of going down the chart here, looking at the HBs antigen, which is the surface antigen of hepatitis B. If that comes back positive when you run the hepatitis panel, if that's positive, then you do have a live active virus, so you have infection. Then there is the HBe antigen, which indicates the presence of active replication of hepatitis B. It's usually seen in phase 2, which is like the chronic hepatitis B infection. So it kind of, that surface antigen eventually will transition to the HBe, E is an elephant, will switch over the longer it's the person's infected. They also will have anti-HBC, which is the core antigen, and that is going to be positive if the person has active virus present, or it was present but cleared by the immune system. It can also be there. And then if a person has IgM, anti-HBs, that's the early antibody production that we see when someone's acutely infected, which then gets converted to the IgG antibodies, which is going to either reflect some kind of like an immunity against HPV. So if the person had the vaccine, you could also see that if the person cleared the infection themselves as well. And so the HGM is going to typically show a active infection acute phase.
That's it.
Does that make somewhat sense?
It does. I kind of lost track of what you're saying because Bart J. Miller, it looks like on Instagram, like that I mentioned, my mom said that thing about hepatitis and I think that's good. But yeah, so we established that you can have infection without having like an acute phase infection, like Mike was saying, depending on the surface antigen. So approximately 350 to 400 million people have lifelong chronic infection of Hep B in the world. Only about 0.5% spontaneously seroconvert per year to that active phase. But yeah, that's like a third of people in the world are running around with Hep B.
It's a lot of people.
Yeah.
So we'll talk about the phases as well, but I do like, there's a chart here that I see that has some examples of if you were to get a panel back, since I just ran through that and maybe didn't make a lot of sense. I'd also encourage you to kind of read through the guidelines too so you can see it because it's still confusing, I'm sure. But they give some examples of if someone, let's say, is immune due to infection. So they were infected, but it cleared. Then they may come back with a HB surface antigen as negative, but their anti-HBC, which is the core, and then anti-HBS would both be positive. Whereas if someone was immune due to immunization, anti-HB core would be negative, but the HBS would still be positive. And then acute and chronic obviously would be based on whether or not you see IgM being positive with as well as the surface antigen and all that. So if you're completely confused and ready to turn this off, go ahead and check out the guidelines.
I was going to say it made sense to me, but if you didn't follow, it's actually pretty important to know with Hep B. That's a pretty important little teaching/learning point for Hep B.
So important.
It is.
Thank God I'm here. So Rich just popped on Instagram Live and said, from RX Radio, and said, I'm just here for the guy with the voice of an angel. So
It's clearly talking about me.
yeah. So we got a comment on Instagram, or not Instagram, iTunes, and it said, their reviews of pharmacotherapy are like okay and like stuff, and it said, but I hate their voices. I hate their voices.
Oh,
I said, especially that kid that's all monotone. To this, we don't know which one he's talking about. I like
and I guess I've got to be the kid, and I'm clearly the monotone one. So
I don't know. I feel like I'm pretty
fine.
monotone, but that's what we're just talking about.
There's nothing that's going to change it.
I laughed so hard when I read that comment. That was the greatest comment of all time.
This is what Mike said to me. I almost crashed the car. I was laughing so hard, and I was like, Mike.
Oh, yeah, I was checking iTunes comments in the car. I was in traffic, to be clearly honest. I said crashed the car to make it funnier. It wasn't a real story.
Right. Okay.
Anyways,
stuff.
yeah, that was our latest comment. That was made my day, actually.
Quality stuff.
Is why most people would think you get a bad rating, you're going to be mad. That was hilarious. The fact that they had to include. I hate their voices. Voices are the worst thing I've ever heard.
Not the first time I've heard that before.
Yeah, no, I mean I don't know what I can do about that. Hard to say.
Yeah, it's good.
We're both taking voice lessons now.
You're not supposed to tell them about that.
Oh shoot, sorry.
It's only Thursday mornings.
Is it?
Every Thursday.
Every Thursday.
Yeah, so I thought this was interesting. Hepatitis B, it can survive for a really long time depending on how cold it is. So it can survive for like 15 years at negative 20 degrees Celsius, 2 years at about 80 degrees Celsius, 6 months at room temperature, 7 days at about 44 degrees Celsius, so a little hotter. But the reason I mention is they found a 400-year-old mummified child, the remains of a child, on a mountain in Korea. And he had hepatitis B virus, and it could be sequenced in the liver, and a viral genotype C was identified 400 years later.
What?
Yep. So it's a resilient little virus, which is why it's so tough to treat.
Yeah, that's geez, a mummy.
Yeah.
We need to get some mummies for the podcast room.
Well, who thought that? We got little Einstein. We could just stick a little waving mummy in there, right?
I mean, you gotta be able to order them somewhere.
I'm sure you can.
But they're cheap.
Yeah. Well, we'll see. We'll have one next week.
If you guys have a mummy or know a guy at a museum, please contact us. So phases of chronic hepatitis B.
Yeah, let's do it.
You want to go through these?
Yeah,
Do you have them pulled up, or do you want me to do it?
You got it.
So the immune tolerant phase, it would be where ALT, liver function test, would be normal. However, you would have probably over 1 million international units per milliliter of HPV DNA. You'd also probably see positive HBe antigen, but your degree of fibrosis and inflammation would be minimal. Now, when you move to immune active, that's when you get elevated ALT. Usually the HPV DNA is greater than 20,000 IU per ml, also with a positive HBe antigen, and then moderate to severe fibrosis inflammation. And then it kind of goes back down. Again, the ALT goes back down to normal when you get to the inactive phase. Usually the HBV DNA is going to be less than 2,000. Degree of fibrosis inflammation can be variable. You'd probably get a negative HBe antigen. And then if it reactivates, you're going to see that HBV DNA jump back up and the ALT jump back up and all that. Inflammation is usually present.
I should have mentioned that the prodrome and icteric phases are more associated with the acute phase hepatitis, but then you have chronic phase, and they have non-specific symptoms in some ways, and then they also have things like chronic as ascites and GI bleeding and mild upper quadrant pain and discomfort, depending on the degree of cirrhosis or disease progression, and of course the big ones: hepatic encephalopathy, hepatic decompensation with progressive liver disease long term. That's what we're trying to prevent.
Yep. Should we talk about the Child-Pugh classification?
Talk about old Mr. Pugh.
So most of you have seen this before, but
or Pugh. I don't even know.
We'll say Pugh.
We'll say Pugh.
Most of you have seen that before, where they have class A, B, and C to kind of talk about how damaged the liver is, and that's based on basically your total number of points, looking at total bilirubin, serum albumin, your clotting factors like PT-INR, whether or not there's ascites present, encephalopathy, and you add those points up. And if you get a really high score, you get a worse a class C, which is no good.
No.
And then a lot of drugs will have, especially ones that are metabolized by the liver, which is a lot of drugs, will have to have dose reductions and things like that, if depending on that Child-Pugh classification score or grade. All right, so if you have a patient, Hep B, obviously we would want to assess immunization status. We would want to get a history of, family history, looking at their comorbidities. We would want to get baseline labs, such, renal, liver, all those fun things. And then we would also want to look for any kind of co-infection. So hepatitis C is very common with Hep B, and HIV would also be something to watch for.
I saw a mention of like a therapeutic vaccine. If they're already infected, we don't immunize, right?
If they're already infected, I would have to double check.
I'm going to go with I don't think so.
Okay, well,
Wouldn't really make sense
we're
to
going
at
to
that
see
point.
if you're right.
Okay, we'll find out. Yeah, people at higher risk for one. I think Mike already mentioned injection drug users, men who have sex with men, also diabetic patients who are checking blood sugar or who use insulin. Pretty much anyone who's going to be sticking a needle in their body is considered at higher risk for acquiring Hep B. So would be people who you would consider the vaccine in. I guess people who are going to certain areas of the country, or certain areas of the world, so it can be spread sexually. So some people elect to get the hepatitis B vaccine for those sorts of reasons if they have concerns for high risk behavior. It is very common. It's blamed in the U.S. for about 5,000 deaths annually, which is not as many as I thought it would be. We have an estimated 60,000 or less new cases of Hep B every year. About 2 million or more have the chronic infection. Worldwide, it's more significant than in America, but we still have it. I think I heard that there are high rates in like nursing homes because they kind of share needles around, or at least maybe not as clean.
A lot of needle sharing in nursing homes. You heard it here, folks.
Or long-term care facilities.
Well, and that's why the whole situation came out with patients that were testing their blood sugar, have diabetes.
Yeah.
And whether or not they should.
I guess it started there.
Yeah, because obviously if you're even just the lancing device could be potentially contaminated.
It could be.
So, that's the ACIP does recommend patients who have diabetes get the vaccine, specifically if they are under 60, I believe. And then over that, it's kind of up to the healthcare professional.
It's interesting. I wonder why.
I don't know, I guess stats.
Oh, I'm sure, but I guess if you get Hep B when you're 60, it's not as big of a deal.
No, I don't know. I'm trying to...
Not time for your liver to decompensate. I don't know.
It's
weird.
I'll have to look that up, the actual reason for it, but...
Yeah. Anything on whether we should vaccinate?
No, I'm still looking. I don't see anything specifically if they're already infected. I can't imagine that would...
Doesn't seem like you would.
No.
If not, you want to hop into treatment?
Yeah, let's do that. Did you go through everything as far as people who should get the Hep B vaccine?
Oh, I went through everything. No,
Okay,
I'm sure I left some out. I only gave like 3 examples.
Okay.
So if you got anything.
Just patients, obviously, that are in close, proximity households that have patients that have HB surface antigen positive family members, things like that that they're living with, should probably consider getting it. Healthcare workers, people with end-stage renal disease. I think you did mention that one, but patients that could potentially go on hemodialysis, peritoneal dialysis, things like that. People with Hep C vaccine or infections, people with HIV, you should go ahead and get them vaccinated as well. And then the other one too is, let me pull it up because I want to make sure I get this right. I believe it's if your LFTs are 2 times the upper limit of normal now is the newest recommendation that you get the vaccine.
Really?
Yeah.
Interesting.
I think that was 2018 maybe.
Okay.
But I said, let me pull this up to make sure I get it right, and I just start talking. Classic.
Classic Mike.
Yeah, persons with elevated. That's testing. Jeez. This is what we like to do: real-time investigation on the recording.
Well, that's what happens when you work and then record.
Yeah, what are you gonna do?
You know what would be ideal
What?
is if recording was like a part of our work. Like, what if we got half a day to record and then we spent like 2 hours looking over it and then an hour recording and we got paid for that?
Man, that would be cool.
Is it like how do people do that?
I don't know. Joe Rogan's doing it.
Well, yeah,
Making a lot more money than me.
maybe we should just be that guy or something.
Yeah, I think I'm just gonna start doing that, I guess.
Well, before we get into the drugs, I'll just mention the vaccines. We already talked about Twinrix, but there is a Hep B vaccine alone. There's a couple of brands: Ingrix B, Heplisov B,
That's the new one.
and Recombavax HB. Ingrix B and Recombavax, those are both 3-dose regimens over about 6 months or so. The new Heplisov is a 2-dose regimen over 1 month, so expedited immunity. And, they have the Heplisov is only for adults. They have catch-up schedules. CDC has all that good stuff whenever you're wondering if I should have this if you didn't vaccinate when you're younger. But for the most part, we're going to get initial vaccines when we're newborns, within 24 months of us being born. If you're in that's if your mother is surface antigen negative. If your mother is surface antigen positive, then they want you to go ahead and be vaccinated within 12 hours of being born.
There you go.
Interesting. So
It is 2 times greater the upper limit of normal, so I was right. Nailed it.
good. Mike got it.
Close one.
Mike's always right. That's
Well-
what we have to realize.
60% of the time, every time.
I mean, statistically speaking, I have to be wrong at least 5% of the time.
Oh, easily.
Standard or whatever that's called, p-values.
Yeah, p-values and such.
Right.
Type 1 error.
Yeah.
Stats. I used to know stats. Yeah, let's jump into treatment.
Okay, let's do it. Go ahead.
So there's several different options, some of which are not really all that used anymore, but you still may see some interferon use, and it's usually the pegylated interferon. And the problem with that is you're going to get really bad side effects, not necessarily super serious, but very disruptive to someone's quality of life. So patients will get like flu-like symptoms, fatigue, mood disturbances, and then they could actually develop things like autoimmune disorders and things like that, which are going to be a little bit more rare.
Yeah, symptoms that seem to mimic the prodrome of the acute phase of Hep B. So that would be a little bit,
Not great.
not great if you're trying to determine whether somebody's about to go into acute phase. I guess you're treating acute phase, so there you go.
Yeah. Some of the more common oral agents that we would use now would be like the tenofovir, and which, if those of you familiar with the HIV treatments, they're both versions of tenofovir by themselves are used in Hep B as well. So you have the tenofovir disoprosyl fumarate and the tenofovir alafenamide. And then you also have the entecavir and lamivudine as well that can be used. I'm pretty sure we've talked about this multiple times, but the tenofovir alafenamide, the different prodrug of tenofovir, there's a significantly decreased dose requirement for that one compared to the original version of tenofovir. The reason for that is that tenofovir has to be a prodrug because you can't absorb the active tenofovir form. And so tenofovir, the original version, the disoprosyl fumarate, was basically absorbed, and a lot of it was activated in the plasma before it actually reached the T cell or whatever was, infected with the HIV or Hep B or whatever the cell was. And so all that activated tenofovir rather would go to the kidneys, which caused nephrotoxicity. It also interfered with the bones because it would cause demineralization and patients who are having bone mineral density loss. And so they developed this new version of tenofovir, which is the alafenamide, which has significantly less activation in the plasma, and it actually gets converted into tenofovir once it's in the cell. So you get very little systemic absorption going to the kidneys and things like that. So the HIV folks were really excited about that, and where you could see the studies for the HIV patients were, I'm sure they have longer. The last time I looked, it was like 144 weeks out. They were still not having any kind of renal or bone mineral density changes. And so the alafenamide seems to be a much better option. And that's what the folks in the UpToDate management of Hep B that wrote that section, they also recommend that they try to treat everyone with the alafenamide formulation if possible. Lamivudine is also used. It's a single agent, but it does have a high instance of resistance with Hep B. So it's super
cheaper
cheap.
too. Yeah.
It is. It's cheap. It's cost effective. We have a lot of outcome data like showing safety and all that for years and years and years, but a lot of resistance. Where there's been some studies that have compared those same resistant strains to things like the tenofovir and the entecavir and didn't see the same resistance. So,
yeah. And it's also may not be as effective as those either.
Yes.
Yeah.
Real quick, Jared on Instagram. What's up, man? He's all the way from Sydney, Australia.
Nice.
And he's a real nice guy. Wrote us that and said he listens to us and he's supporting the podcast. So all the way from other side of the world. It's pretty awesome.
We love our Australian listeners.
Australia actually is like our fifth most downloaded place.
They're like the nicest
geographically.
people over
They
there.
are nice. They have awesome accents.
They spend their lives almost getting killed by wild animals.
They would
they're
never
so
get
nice.
a thing on Instagram or on iTunes about terrible voices like we do.
Exactly.
They'd probably get all the ratings.
I wish I had an accent like that.
Me too. We could start practicing, I guess.
That would be
Be the worst.
that would be the worst.
All right. So, as far as treatment goes, the pegylated interferon is going to be a weekly treatment that lasts for 48 weeks. And then the other treatments are going to be typically for 12 months. And then a lot of patients or a lot of providers will continue the treatment for 6 months after that to ensure clearance and the virus is inactive at that point. But just some real quick, some of the adverse effects to watch out for with tenofovir, like I said, could be long term. I mean, we're still expecting not to see renal and bone issues, but it could happen with alafenamide as time goes on. Some of the really rare things with especially with the original version of tenofovir would be like Fanconi syndrome, osteomalacia, things like that. We wouldn't expect to see those with alafenamide version. And then the entecavir, things like lactic acidosis could potentially occur. Osteomalacia can also occur with that as well. Not super common, but things to watch out for.
And I don't know that we mentioned the non-interferon options are reverse transcriptase inhibitors.
Yeah.
So there are multiple types of antivirals, but the ones in Hep C are going to be reverse transcriptase inhibitors.
Yep. So labs to monitor, liver function, CBC, thyroid, all the usual stuff we would probably be looking at. And then definitely if you're using the original version of tenofovir, get them renal labs.
Yep.
And then pregnancy, lamivudine, tenofovir has been studied in pregnancy as well, but lamivudine I think has the most data in pregnancy. And if you are going to use pegylated interferon, do not use it in your psych patients if you can help it. So, what else? What else can we talk about?
That's pretty much all I got.
Whew.
We could probably do a follow-up Hep B. Look more in detail.
We actually know some stuff?
Yeah,
That'd be cool.
I bet you we could. I bet there's enough stuff there.
I would say sure there's enough stuff there.
I mean, we could do
because the other thing is that we didn't mention is who gets treated and who doesn't.
Right. So we didn't go very deep because there's a lot of different guidelines. We didn't really go very deep into treatment regimens.
Yeah. So as far as who's actually indicated for getting treatment. So if a patient has let's say they're active, but they're not showing decompensation, they're not showing cirrhosis or anything like that. There's some situations where treatment may actually have, if they're too well off, treatment is actually not recommended at first because the treatment seems to be very low efficacy as far as that seroconversion. So if this person's older, has a family history of, hepatic carcinoma, something like that, then you could consider, but typically we wouldn't. And then as they get kind of worse off, I guess you could say, then that's when we would start looking at, for sure treating.
And I guess, so if they have infection but it's not active, we're just not treating.
Yeah, and then there's even patients that if you have patients with cirrhosis, with compensated Hep B infection, and there's sometimes where those treatments could go on indefinitely, so there's a lot of different nuances like that, and that's I think that's going to take too long to go over, but we want to make sure we at least cover the drugs and things like that. So I would definitely encourage you for something like this to check out like the Infectious Disease Society of America guidelines, check out UpToDate, Dynamed, any of those things you have access to, and look through the specific patients that are getting treated.
Yep, I agree.
Cool. Anything else?
That's all I got, man. Glad to be back.
Yes.
Skipped out on me on the last one.
Yeah, sorry about that. I actually made a joke right at the beginning of the podcast.
I heard.
I was
Listen to the first 5
Cole
minutes.
doesn't even know that we're recording this right now. But so hopefully June rolls around, no more traveling, and we'll be able to.
Yeah, Mike taking vacations and stuff. What's that about?
Ridiculous. I didn't want to.
Well, it's the time of the year. Well, first of all, it is so hot here. It's unbelievable. There's like a heat advisory this weekend, by the way. But everybody wants to come. So I've got people in town like every single weekend. It's crazy.
Unbelievable.
Family and whatnot.
So we'd like to get to where we're recording like 8 episodes a month. At least I'd like to get to that.
That's the dream.
And so that's hopefully coming soon. We just got to figure out.
I had an idea,
way.
and I'm going to say it on air so that people hold us to it. Yes. Well, if we actually have time and it's not 11 o'clock at night, we could record 2 at a time. But another thing, which not tonight, because I want to go home and get some sleep, but we could just, right after the podcast, we could just come up with our next topic. And then that way we're not scrambling the day of the podcast to figure out a topic. We just take 10 minutes and we just talk about it and we come up with a topic.
Listen.
What an idea.
Here's the thing about that idea. I hate that idea because I really like scrambling the last minute and it gives like panic and like.
But then as we have time, we can look over it and,
Nonsense.
Because if
I like to just spit it off the top of my head. That way it's like partly right.
We'll see what you guys.
We just lost all of our followers, by the way.
Also, I was thinking, because I was listening to a podcast that had not a jingle, but people just kind of made little, I don't know. If somebody took our music and just put words to it and then sent it to us. I was thinking about this because somebody emailed us and sent us their song. It was a band. I don't know if you saw this.
No, I didn't see that.
They wanted us to like highlight it.
Really?
Yeah, and I was like, I don't know, they're from France or something. But anyways,
forward it to me. I didn't see that.
Yeah, I'll forward it to you. But anyways, I don't know that we will.
I'll highlight you on Instagram.
But I was thinking, like,
we'll
what if somebody took our music and like remixed it, put some words to it? I wonder if we would toss it in somewhere.
Maybe.
Yeah.
Talked about how crappy our voices are.
Yeah, I know.
Oh man.
Just took our voices and
made them
mix out of it.
Magnificent. Anyways.
Fatty Poo remix.
There you go.
Yeah.
Cool. Well, thank you guys so much for listening. I know we joke around, but we really do like doing this, and we try to bring some kind of value with this. And we know these are basic overviews, but for those of you who do like the podcast, we are very appreciative. And we'd love the nice comments, and honestly, the bad comments kind of make us laugh. But if we can keep those to a limit, that'd be great. No, I'm just kidding. Comment away. But we really appreciate the ratings and everything that we've gotten lately, and everyone's been real supportive. The emails we've gotten have been great. And several residents and all kinds of things that have emailed us has been awesome and encouraging. So thank you guys so much for that. And, we will do our best to get back to all the direct messages on Instagram and Facebook and email and all over the place. And I keep finding things on LinkedIn. I'm like, oh, geez, I forgot this one. It's been a week old. So if I don't get back to you, like I always say, it's not because I don't like you. I'm trying. Cole's doing the same thing. But thank you guys so much. And we will be back soon. See ya.